Hey, I'm Matt Geiger. This video is all about the history of health insurance in the US, and it really doesn't go back too far, beginning around the 1920s. So medicine as a science was still relatively new at this point, and treatment was just starting to shift from doctors making house calls to hospital care for the general population. The problem was, similar to how it is now, hospitals were really expensive to operate, and they had huge fixed costs, regardless of whether they saw a ton of patients or no patients. So to deal with that constant cash flow problem, individual hospitals began offering healthcare on a prepaid basis. In 1929, the first employer-sponsored hospitalization plan was created between teachers in Dallas and Baylor University Hospital. Under that plan, members were covered in that one specific hospital for up to 21 days in the hospital for a fixed fee. As the idea of health insurance gained steam, though, groups of community hospitals began working together so that they could negotiate better deals, forming Blue Cross organizations. In general, healthcare was cheap around the 1920s and 30s just because healthcare wasn't very good. But that was beginning to change through the 30s and 40s. Healthcare was improving as a legitimate science, and more people were moving to cities, making it possible to treat people on a larger scale. Also, the American Medical Association began to take a more active role. They increased licensing requirements and raised medical standards so that the industry could develop a level of trust and competency it didn't have before then. Because of all this happening, Blue Cross plans spread rapidly and states moved to regulate them the same way that they regulated life insurance or car insurance companies, which would require them to meet reserve requirements and pay taxes. But American Hospital Association and American Medical Association lobbied hard to prevent that from happening. They ended up cutting a deal offering to operate Blue Cross organizations as nonprofits, and in return, they promised to enroll anybody who applied without price discriminating against sick people, meaning not charging more or denying coverage for pre-existing conditions. But it didn't take long for the problems with this compromise to become apparent. Through the 30s and the 40s, commercial health insurance plans began to pop up to compete with Blue Cross plans. Commercial plans grew faster than Blue Cross plans, mainly because they could cherry pick healthier populations, and they charged less because of that. Remember, Blue Cross organizations were allowed to be nonprofit by promising specifically not to do that. Before World War II, most insurance was actually individually held, but that changed as a result of the war. Businesses had trouble finding workers because so many people were off fighting. The War Labor Board was worried that inevitably wage increases would end up hurting the war effort, so to prevent that, they restricted wage increases. But that didn't include fringe benefits like health insurance. Since businesses couldn't attract more workers by raising wages, they offered more fringe benefits, most importantly here, health insurance. Every employer began offering health insurance, making it a system-wide perk of employment. Employer-sponsored health insurance was cemented as a systemic fixture in the 50s when the Revenue Act of 1954 allowed companies to deduct the cost of health insurance without employees being taxed on the benefit. In the 1940s, health insurance enrollment was 20 million people, but by the 50s, that rocketed up to 142 million people. As medicine improved, insurance companies began providing catastrophic insurance, covering serious, long-term, expensive-to-cure illnesses. By 1958, 75% of people had health insurance, but for the 25% who didn't, healthcare expenses were becoming a major problem. In response, President Lyndon Johnson signed bills creating Medicare and Medicaid in 1965. Medicaid is health insurance for the poor, but the federal government doesn't provide the insurance itself. The federal government gives states money, matching what each state spends dollar for dollar. Who's covered, what's covered, how much participants pay, and administration is left up to the states, and it varies a lot state to state. Medicare, on the other hand, is a national health insurance program for Americans 65 and older, and then younger people with disabilities. Medicare Part A covers inpatient hospital stays. That's a hospital visit requiring an overnight stay. And Medicare Part B helps pay for outpatient services, so doctor visits without an overnight stay needed. This is primarily funded by a payroll tax of 2.9%, taken directly out of your salary. The medical profession fought hard to prevent socialized medicine like this, so to get the AMA's acceptance, Medicare was structured similar to the existing Blue Cross and Blue Shield plans, a cost-plus model, which is basically how it is still today. Over 3 decades later, Medicare Part C was passed under the Balanced Budget Act of 1997 by President Clinton. Part C plans are known as Medicare Advantage and let patients get private insurance that covers, at a minimum, the same conditions that Parts A and B cover, and Medicare pays the private insurance company an amount equal to what it would have cost Medicare to service that person's health care. President George W. Bush signed Medicare Part D into law as part of the Medicare Modernization Act passed in 2003. Part D covers prescription drugs. These are private plans, just like Part C, that are approved and regulated by Medicare in terms of maximum deductibles, structure, required drug coverage, things like that. In return, Medicare subsidizes these drug plans for low-income seniors and also if catastrophic drug expenses exceed a certain level. In 2010, President Obama signed into law the Patient Protection and Affordable Care Act, or Obamacare. This left most of the health insurance structure in place as far as Medicare and employer-sponsored plans were concerned. It really targeted people who made too much to qualify for Medicaid, were too young to qualify for Medicare, and couldn't get health insurance through an employer. To do that, it had a few parts. It created insurance exchanges of private subsidized insurance with subsidies based on income. The federal government encouraged the expansion of state Medicaid by covering 100% initially, then 90% indefinitely of expansion costs. Remember, under traditional Medicaid, the federal government covers 50%. And it prevented insurance companies from charging higher rates to individuals with pre-existing conditions. It also required that everybody get health insurance or pay a penalty, but that penalty was removed a few years later under President Trump. And that takes us to the present. I have two key takeaways from this history. One is a story of unintended consequences. A lot of time intentions are pure initially, but lead to systemic issues down the line. So for example, we didn't set out to create an employer-based insurance system, but incentivizing a seemingly harmless perk ended up defining our entire health insurance system. A second takeaway is the power of lobbies. The AMA was always a significant presence when government passed legislation, or more importantly, when it couldn't pass legislation. Considering the AMA's power and influence, it should come as no surprise that our healthcare system has continued to eat up an ever-increasing portion of our national GDP. Thanks for watching. Hey, if you found this video interesting or useful, please give it a thumbs up, put a comment below, and subscribe to my channel to get any updates on new videos. If you didn't like it, you should probably go ahead and put a comment below too to let everybody know. Either way, thanks for watching.